Welcome to the campus of North Idaho College and today's broadcast of the North Idaho College Public Forum. The crew is comprised of North Idaho College television students. Your moderator is North Idaho College political scientist, Tony Stewart.
To our viewers, we'd like to announce another milestone for the North Idaho College TV Public Forum. Today, we're happy to announce to you that this is the 600th taping of the North Idaho College Public Forum, and we're happy to have been with you this long. Our program is a very important one today. Our subject is diabetes, which is a disease that has affected many homes throughout America, and we're very fortunate to have with us today two guests that will be experts and be able to discuss with us that very important topic. First of all, I welcome to the program Dr. Patrick Pardon, who is an ophthalmologist in Coeur d'Alene and has specialized in that field, but also works as that relates to diabetes with some patients. Also, we have Dr. Rob Reneboom, who is also a specialist in our city. He is in pediatrics, and he too works with this, among other things. Gentlemen, it's a pleasure to have you with us, and you've been very generous to come and spend some time in advance, and we're looking forward to the interview. At a later time, the program will introduce a mother of a child that has diabetes, and that will be part of the program also. This time, I'm happy to welcome back to the program once again Janelle Burke, a regular panelist and an attorney, and with the 1st Judicial District in Idaho to commence our questioning.
Doctors, what exactly is diabetes? Can you give us a definition and tell us what the disease is?
Well, diabetes is a very complex disease, but the basic problem that diabetics have is an inability to control their blood sugar. Normally, the body very carefully monitors the level of blood sugar and keeps it within a very tight range. And there's an upper level that the sugar is never allowed to go above and a lower level where the sugar doesn't drop below. The body uses the hormone insulin to accomplish this control. So, for instance, after someone eats a meal, the blood sugar level begins to rise, the level of insulin also begins to rise, and the insulin stimulates the cells to use the glucose, and that keeps the glucose level from going up out of the normal range. And similarly, when the glucose starts to drop, the insulin level starts to drop. The problem that diabetics have is a deficiency of the hormone insulin, and consequently they aren't able to appropriately regulate their blood sugar levels. What happens after a diabetic person eats a meal is that the blood sugar level starts to rise, and there isn't enough insulin secreted to keep the sugar level under control. So the sugar level goes up out of control and outside the normal range and results in a high blood sugar level or hyperglycemia. So the basic problem that diabetics have is a deficiency of insulin, and consequently they get blood sugar levels that are too high. Unfortunately, there's a little bit more to it than that. The blood sugar levels themselves are a little bit dangerous because they cause damage to tissues in the body and to blood vessels and other organs. So diabetic patients will develop complications from the high blood sugar levels. So it's a simple defect of insulin secretion, but it has widespread effects throughout the body.
What types of diabetes are there?
Well, there are two main types of diabetes, a type 1 and a type 2. The type 1 diabetic is a person who really has next to no insulin available. And that person will be dependent on insulin injections for the rest of their life. Every day they'll have to take a certain amount of insulin to simulate what their pancreas ordinarily would have put out before each meal. So that's an insulin-dependent type of diabetes, or type 1. Type 2 is a non-insulin dependent type of diabetes. And patients with that type of diabetes may have a certain amount of insulin. They may even have excess amount of insulin. The problem is the insulin doesn't work as effectively. And they usually don't need to take extra insulin injections, and instead their disease can be controlled either with dietary regulation or with weight loss. And some of the patients will need to take an oral hypoglycemic agent. That's a medicine that can be taken by mouth that will help decrease the blood sugar. Some of the type 2 diabetics will need to take insulin, but probably only for a temporary or brief period of time, and they aren't dependent on taking insulin injections for the rest of their lives. Now, the type 1 diabetes used to be called juvenile onset diabetes because most of the people with type 1 diabetes have the onset of their disease during childhood. Can even occur as young as less than a year of age. Even infants can develop type 1 type of diabetes. But it's been shown more recently that young adults and even some older adults can develop type 1 diabetes. So the term juvenile diabetes has been dropped and it's just called type 1 diabetes. The type 2 diabetes, the non-insulin dependent type of diabetes, used to be called the adult onset type of diabetes or the maturity onset type of diabetes. And but there are occasional children who develop a type 2. That's pretty rare, but for that reason that term has been dropped. Now in pediatrics, where we deal exclusively with children, virtually all of the children that we see have the type 1 diabetes. And of the two types of diabetes, the type 1 diabetes is probably more severe, involves more complicated efforts to control the disease. But with both types of diabetes, the severe complications that we'll talk about later can occur.
To our physicians, I have a couple of questions in two different areas as we pursue this important topic. First of all, we hear a lot about how common is this disease, what percentage of the population does it affect, and the kind of person gets it or who gets it.
Well, diabetes is a very common problem, and it's a little difficult to give exact percentages because population studies sometimes aren't very precise, but probably the prevalence is about 2 to 4% of the population. So if you take that type of figure and you look at the northern Idaho or the Inland Empire area, in eastern Washington, northern Idaho, and western Montana, there are probably about 1 million people. And that equals about 30,000 diabetics. So there are a great number of diabetics in this area. Some of them are adult onset or type 2 diabetics who have mild disease and aren't aware of it. And that number also probably includes about 400 children with the severe type 1 diabetes. Overall, in the United States, there are probably about 5 million diabetics. So if you look at the entire population of the United States, there are as many diabetics as there are people in the state of Washington. And that's quite an impressive number. The incidence is also increasing. Diabetes tends to be more common in older people, and as the population of the United States is getting older, diabetes is becoming more common. And another thing that's increasing the prevalence is better care for diabetic patients. They're living longer and they're having more children, and this is resulting in a higher incidence of diabetes. So it's a very common problem and becoming more common.
When you indicated that they're having children, can I read into that in relation to who gets this? Does it have some genetic connections?
Yeah, it certainly does.
Genetics plays a big role, both in the type 1 and the type 2 diabetes. The type 1 diabetic probably has some genes that make that child or that person susceptible to developing diabetes. Something about the genes on his chromosomes that make the person more likely to develop the diabetes. If you look at diabetic children, about 10% of those children will have somebody in their family who also has type 1 diabetes. And if you look at the siblings of a child that has type 1 diabetes, about 6% of the, a sibling has a 6% chance of also developing type 1 diabetes somewhere along the childhood years.
We're going to pursue this in a certain order. It makes it easier for our viewers and we too. And I don't want to get into some of the treatment because we'll talk about how you deal with it. However, before I turn it back to Janelle and what I'm asking, even though you've indicated there's a genetic connection, but for those who might relax saying, well, there's no genetic history in our family of diabetes, can they do certain things or their lifestyles that might help bring on diabetes?
Well, for the type 2 diabetes, the adult onset type of diabetes, where there's also, by the way, a familial tendency. There's a strong family history of diabetes with type 2 diabetics. And if identical twins, for example, if one twin develops type 2 diabetes, there's almost a 100% chance that the other twin will eventually develop type 2 diabetes. So there is a familial or a genetic component to that type of diabetes as well. But with the adult onset type of diabetes, obesity probably is a predisposing factor too. About 70 to 80% of adult onset or type 2 diabetics either are or have been overweight, and somehow that seems to disturb the regulation mechanisms for glucose metabolism and makes them more susceptible to developing the type 2 diabetes. In children, obesity probably doesn't play a role. Other factors are more important.
Thank you. Janelle Burke.
If there are other causes of diabetes, please feel free to address those, but if not, I'll move ahead to ask what are the symptoms?
Well, I might just mention something about the causes. There is the genetic predisposition that we've just talked about, but the other thing with type 1 diabetes, with the childhood onset type of diabetes, the immune system may play a role. If you study the blood in newly diagnosed juvenile diabetics, you'll find that there are high titers of antibodies to the insulin-producing cells of the pancreas. So it's as if these children have, it's as if their immune systems have mistakenly and unfortunately produced some antibodies that destroy that part of the pancreas that produces the insulin. The other thing that's been implicated but not proven is the possibility that viruses may provoke the disease. Coxsackie virus has been implicated, and it's possible that certain viruses in certain individuals, if they are genetically predisposed to do so, the virus may attack the insulin-producing cells of the pancreas and cause diabetes to occur. But it's probably a combination of all three of those things: genetic predisposition, virus infection, and involvement of the immune system in the type 1 diabetes. In the adult onset type of diabetes, viruses and the immune system probably don't play a role.
Is it possible for a shock to the nervous system to cause diabetes?
Not
accidents
no.
Or shocks. Then what are some of the symptoms of diabetes?
The classical symptoms, which occur quite dramatically in children who develop diabetes, are, first of all, the parents often notice that the child is beginning to urinate more frequently and in larger amounts. So they're constantly going to the bathroom and urinating a large amount, maybe getting up in the middle of the night, which they hadn't been doing before. And this is due to the fact that they have glucose that is spilled from the bloodstream into the urine, and that glucose tends to pull more water into the urine, and they have a larger volume of urine. Because they're urinating so frequently and in such large amounts, they actually become thirsty. So the parents may notice that the child is thirsty all the time. Thirdly, because they don't have the insulin available to help utilize the glucose that's in their bloodstream, they are in a sense starved, because the glucose that gets absorbed and gets into the bloodstream then just stays there and piles up and doesn't get sent into the cells where we need to have it. And so they are relatively starved, and they feel hungry all the time. And they begin to lose weight in the severe form. So those are the classical symptoms of the onset of diabetes.
Something else that is really important, I think, for our viewers, and I would like to remind our viewers who tuned into our program late that we have two physicians from Coeur d'Alene that are discussing with us diabetes, and we're talking about the whole process. And I would like to continue to move into some other aspects now that we've talked about who might get it and the causes and so forth. There's a lot of different treatments, and I know this is a very complex area. In talking to you before, there's some treatments that have been used in the past, and now they're changing. But with the time that we have, let's start out with the historical aspects of treatment and then move into some changes taking place. If you get a patient, I know they're different, but based upon their history and their condition, what do you suggest as treatment?
Well, just to briefly answer the first part of your question about the historical aspects, diabetes is a disease that has been recognized for thousands of years. It was described in the early Greek and early Chinese literature. These physicians in that time recognized the symptoms. The term diabetes comes from a Greek root, and the Greeks actually gave the name diabetes to this symptom complex. So the symptoms and the disease have been recognized for a long time. But it wasn't until 50 years ago that insulin became available for treatment of diabetics. And so even though the disease has been around for several thousand years and recognized, there has not been effective treatment available until the last 50 years or so. Now, insulin therapy is the mainstay of treatment for most diabetics. And Dr. Rennebaum does more in the day-to-day management of diabetics than I do, and perhaps he could go over some of the treatment implications.
The use of insulin, injections of insulin with a needle into the subcutaneous tissue is the cornerstone of treatment for diabetes, at least for the insulin-dependent or type 1 type of diabetes. And the principle is that we try to use insulin in as close a way or in a similar fashion to the way the normal pancreas pushes out insulin to help handle the blood sugar. Dr. Pardon mentioned earlier that when we ingest a meal, when a normal person ingests a meal, the blood sugar tends to rise, and the pancreas senses that rise in blood sugar and pushes out a certain amount of insulin that's just perfectly appropriate to bring that blood sugar down into the safe range and to help drive some of that blood sugar out of the blood into the cells where it's needed. We try to mimic that situation by artificially giving injections of insulin. Now, the ideal way to give insulin would be to give a small amount of insulin before each meal is ingested. And there's a type of insulin called a short-acting type of insulin that peaks in about 2 to 4 hours and then lasts for about 6 hours and then is gone. And so a diabetic can be instructed to take a dose of the short-acting insulin just before breakfast, and then a half an hour later eats the breakfast, and then the blood sugar tends to rise, but then that insulin starts to peak and it brings the blood sugar down, and then by just before lunchtime the insulin is worn off and the blood sugar has been maintained at that normal level. And then the patient can give another insulin injection just before lunch and then just before dinner. And then, since there's a tendency in the nighttime hours, even while the person is asleep, to have a slow buildup in blood sugar for complex reasons, we also would have them take a small dose of insulin at night to tide them over for the nighttime hours. Now, that's called a 4 shots per day plan, and that is tough for a lot of people to comply with. There is a longer-acting insulin that lasts for 12 hours, and an even longer one that lasts for up to 24 hours. And so what's more commonly done is that a diabetic will take a combination of a short-acting insulin and a long-acting insulin before breakfast, and that kind of handles the breakfast and then handles the lunch and into the afternoon. And then just before supper, they take a second dose of a similar combination in a slightly different dosage, and that covers their dinner meal and then covers their nighttime tendency to develop a high blood sugar.
Are there some cases, though, of patients that, for whatever the reasons may be, that are more mild and they don't need the insulin, that you have other treatments?
Right, I'm only talking about the type 1 diabetics. Unfortunately, we didn't mention this before, but fortunately, probably less than 5% of all diabetics have the type 1 diabetes. But in children, most children who have diabetes have that type of, have the type 1 diabetes. In the type 2 diabetes, the adult onset form, probably most of those patients can control their situation simply by cutting down on certain foods, the simple sugars that tend to give a very rapid rise in blood sugar, and stick to more complex sugars and a more healthy diet. Most of the adult onset diabetics are obese to begin with, and so by simple weight reduction, somehow that helps make what insulin they do have more effective, and that can help control their diabetes. And then the oral hypoglycemic agents may be necessary for some of the adult onset.
Is there any research indicating that we may be able to use treatment in the future that will not involve injections, that insulin could be taken in another form?
Well, the thing that's being experimented with at the moment are pancreas transplants. And just in the last couple of years, at some of the major medical centers around the country, Minnesota being one in particular, there are many patients that are receiving transplants, just like a kidney transplant instead of a pancreatic transplant. The idea being that that pancreas then will be able to control the blood sugar. That's been reserved, however, for patients that have very severe diabetes and that have already developed very severe complications. And there's still lots of problems with that. A lot of immunosuppression is necessary, that's dangerous, and so it's still very experimental. The other somewhat exciting approach to, but which still requires injections of insulin, are insulin pumps. And there's a fairly simple type of insulin pump which is already in use. And with this pump, it's about the size of a cigarette package, and it has a syringe built into it, and it has a mechanism whereby that syringe will administer a certain amount small amount of insulin continually, and then just before a meal it can be programmed to push in a larger dose of insulin. And the patients will wear this around their waist or abdomen, and there's a little plastic catheter that goes from the syringe, and it has a needle on the end of it, and the patients just stick the needle in through their skin into the subcutaneous tissue. And the pump does the work, so that they don't have to give themselves a new injection 4 times a day or twice a day. Unfortunately, that system has its limitations. Maybe someday there will be a completely computerized system that will not only administer the insulin, but will also automatically determine the blood glucose level, and then have a feedback mechanism so that just the right amount of insulin is introduced. But that is down the line.
Janelle Burke.
Can the level of glucose be monitored?
Well, that's the other very important part of the management, particularly of the juvenile diabetic or the type 1 diabetic. The patient or his or her family needs to monitor whether the dosage of insulin that they're giving is adequately keeping the blood sugar in a certain range. And the way they monitor it these days is usually by home blood glucose monitoring, where the family purchases a little machine and then the child's finger is pricked and a drop of blood is obtained and inserted into the machine, and the machine can tell them exactly what the blood glucose level is. And so parents can be taught how to check the child's blood glucose level even several times a day, particularly if the child is having lots of difficulty, and then to periodically check and make sure that the dosage is in the right range. The other way of monitoring the blood glucose level is to check urines, and you can see how much sugar has spilled into the urine, and that is an indirect reflector of how high the blood glucose has been.
Janelle, I think we should invite our physicians to introduce some parents that we have with us today, and they have their child, and maybe this would be a good time to allow you to interview them about how to deal with this as a home care and protection.
We thought we would bring the Bensons with us today. This is Megan Benson and Jim Benson and their little 3.5-year-old Jamie Benson, who has had diabetes since August of this year, and he has the type 1 diabetes, insulin-dependent diabetes, which means he will need to take insulin injections for the rest of his life. And we thought we might ask the parents to explain what they need to do as a family to manage his diabetes at home.
Well, right now Jamie's taking 4 shots a day, and we're doing 6 blood checks a day. So we get him up early in the morning and start, and right now we're even giving him an injection at midnight. So it's a long day, but we're not doing the urine testing anymore. We found for Jamie that wasn't particularly effective. So that's basically, for 4 injections and his 6 blood checks throughout the course from a 7 a.m. until midnight day.
They're using the 4-dose per day regimen. And we've just started doing that with Jamie because he was previously on the 2-dose per day. And with a young child whose life is quite erratic, his exercise level changes hourly, is not consistent day to day, his meals are not consistent day to day, and that makes it difficult to control with just 2 doses a day. So we've temporarily have them on the 4-dose per day regimen, and temporarily having them check the blood sugars quite often. Eventually he'll only need to check his blood sugars on 1 or 2 days a week, just as a check to make sure that the dosage is appropriate.
I would like to ask one other question, if I may, to the parents. For those who are watching and they may be just beginning to experience this process, and maybe the physicians respond to this too, is this something that took some training, or do you find it comfortable to do it?
Well, Jamie spent 2 weeks in the hospital, and we spent a lot of time with the diabetic coordinator at Kootenai Memorial. That's Carla Gentry. And she taught us how to check his blood, and the nurses instructed us on his injections. And it took some time to get used to it, but now it's a matter of routine. Jamie doesn't have any troubles with it. He doesn't complain. So even though it's only been a short time, only about 4 months, we're used to it. It doesn't bother us anymore. It used to. The injections were hard, but we're used to it now.
Well, Jamie is very active and energetic and a fine young man. Do the physicians have any other questions for the parents, or
I
Janelle?
have a question. Is there a support group in the area for parents of diabetics, or even for diabetics in general?
We are just now forming the Coeur d'Alene chapter of the American Diabetes Association. Tony Spatola has started the group, and we've only had one organizational meeting, and there's another one coming up soon. And we're hoping to start, Jim and I are particularly interested in a support group for other parents, so that we can get together and share our experiences and problems with having a juvenile diabetic.
My second question is, at this point, of course, you're helping your son, but later on in his life, will Jamie take that responsibility himself?
Yes, he will learn to inject himself and to check his blood, probably along in grade school. Dr. Renenbaum has said that usually they like to go to camp and they learn from other children and camp counselors who themselves are diabetic how to do their own injections. Jamie helps as it is. He's learned to help to insert the strips for his blood glucose testing. So he's already learning how to do it.
I think one other point I'd like to make is it's a relatively new idea in the last 2 or 3, 5 years maybe, to make a much greater effort to control the blood sugar level, at least in the juvenile diabetics. 10 years ago, physicians tended to be fairly lazy, and the families were allowed to be fairly lazy, and it was felt to be all right if they spilled a fair amount of glucose. It was all right if their blood sugars soared up into the 200s and 300s or higher. And it was not felt to be quite so important to control their blood sugars in such a narrow, close to a normal range. But a lot of studies have suggested that the future complications of diabetes are due to poor control, and that's why in recent years we've been trying to control them much more tightly.
We're just running out of time. We only have about a minute, and I don't want to leave the program though without actually warning our viewers that if you don't keep this under control, there are real serious consequences, and we can't even explain them. Could you just tell us some of the complications that people have if they let their diabetic problem increase?
There are a lot of complications that can occur with diabetes, but most notably it affects the blood vessels of the body. It can cause high blood pressure, it can cause heart disease, and it affects certain specific organs that are dependent on the blood supply, like the eyes and the kidneys and the nervous system. So diabetics tend to have more problems in those particular areas. I think it's important to emphasize that there is treatment available in many of those areas. Much of the treatment is new and is very helpful. But one of the most important things is, and Dr. Renenbaum just mentioned this, early detection and good treatment of the diabetes is important, and early detection and early treatment of the complications will minimize the amount of disability and the problems that the diabetics get.
I'm so sorry to interrupt, but time is up. On behalf of Janelle Burke, I want to thank both of our physicians and our family for being with us and discussing a very, very important topic of diabetes, and I want to invite these physicians to come back on this and some other subject in the future. We appreciate your time, and you've been generous with it and very helpful. Ladies and gentlemen, please be with us again next week. Until then, have a good week. I am Tony Stewart.
The North Idaho College Public Forum can be seen at this same time each week over this station. This production was videotaped earlier by a North Idaho College student crew for viewing at this more appropriate time.